Kia ora koutou and welcome to Goodfellow podcasts. This episode is kindly supported by the Royal New Zealand College of General Practitioners. I'm Dr. Louise Kugler, a GP specialist, and today I welcome back to the podcast Dr. Ryan Paul to discuss continuous glucose monitors and automated insulin delivery devices. Ryan is an endocrinologist and clinical director of the Te Whatu Ora Waikato Diabetes Service. He is an associate professor of medicine at the University of Waikato and a clinical associate of the Maurice Wilkins Centre. He is the immediate past president of the New Zealand Society of Endocrinology and president-elect of the New Zealand Society for the Study of Diabetes. He is also co-chair of the newly formed National Diabetes Network. Ryan has created the Advanced Diabetes Management course for all health professionals in primary care and was awarded the New Zealand Medical Educator of the Year in 2019. Kia ora, Ryan, and welcome back to the podcast.
Kia ora, Louise. It's great to be back and talk about this momentous moment in diabetes care. It really is a major milestone which we should be celebrating.
So today we're talking about automated insulin delivery devices or insulin pumps. So these may be new to some of our listeners. I wonder if you can tell us about these and how they work.
Sure. So what automated insulin delivery involves wearing an insulin pump and a sensor and then an algorithm to help control the glucose levels. So for example, if the glucose levels are high, the pump will give more insulin. If the glucose levels were heading down, the pump will give less insulin or even suspend if needs be. Now, the algorithm is either on the pump, such as what we'll have in the Tandem Control IQ system, or it may actually be on the phone, which we'll have with the MyLife Ipso and CAM APS system.
So, Ryan, what are the advantages of insulin pumps?
Well, the major advantage, particularly of automated insulin delivery, and it is a completely different kettle of fish to non-sensor augmented pump therapy or wearing a pump that doesn't talk to a sensor, is what automated insulin delivery will do for the first time ever that we've had this available is actually allow people to have insulin without doing anything themselves. So with these systems, though, you still need to tell the pump when you're eating, but it will mop up any mistakes that people have made with their carbohydrate counting. And what it does mean is most of our whānau with type 1 diabetes or pancreatic diabetes or anyone wearing these systems will actually wake up usually with a fairly normal glucose level. And we've had people actually describe for the first time, in their diabetes journey, they've actually forgotten they've had diabetes. And that's really powerful to hear.
Gosh, that's wonderful, isn't it? So thinking about the disadvantages now of the automated insulin device.
Well, it isn't everyone's cup of tea. And it is remembering that people will be attached 24/7 to their insulin pump. Now, the systems we've got funded at the moment do have tubing, so we don't have funded patch pumps available. Some people may choose to do that privately. What wearing a patch pump is that contains all the insulin inside it, and that will basically administer the insulin without any tubing whatsoever. So for some people, being attached to something is a step too far, but for the vast majority of our whānau with type 1 diabetes and those eligible, it is a very acceptable and well-tolerated form of technology. For example, if we go to countries where this technology is funded overseas, we probably see at least 80% of people on this technology. So it shows that, the major change in the diabetes landscape that we're at.
Thinking about who would benefit from this type of therapy.
I guess the biggest point I'll make here is that it'd be really great for all of our high-risk whānau in particular to be the ones that will have the most to gain to benefit from this technology. So I'm talking about all those with high HbA1cs, our Māori and Pacific whānau with type 1 diabetes. We need to get past this myth that it's just a European disease. It's all our disabled whānau, those with complications. So all our high-risk people will be able to get so much out of this technology. They're the ones we should be prioritising first. They won't be the loudest. I can guarantee that all of our diabetes services across the country will be bombarded by people who want to get onto these systems as quickly as possible. To be clear, there's no additional funding or resources available for this. So it's likely going to take many services years to meet demand. It's that major stress on the system. And also, to be clear, no one across the motu is expecting primary care to be starting automated insulin delivery. This is all to be started in secondary care and ideally within a specialised multidisciplinary setting. So dietitians, nurses, doctors all still remain as important as ever in the team, but it is going to take us time. So part of what would be really great for primary care to help is just getting that message about how big that workload is in secondary care, and it's not going to be likely done, in a timely fashion that people want.
So the Pharmac criteria has changed as of October 1 this year, 2024. Can you tell us about the eligibility criteria?
Basically, for both CGM and for both automated insulin delivery, it's anyone that will benefit from wearing this technology, which, to be fair, is pretty much everyone. It may not be their cup of tea, as I said, but everyone becomes eligible. Unlike historically, where people with insulin pumps had to meet certain HbA1c or hypoglycemia criteria. So full credit to Pharmac for widening that, because that did create inequities with that criteria. But just to be clear who is eligible, it's all those with type 1 diabetes or pancreatic diabetes or monogenic diabetes with insulin deficiency. So that includes mitochondrial diabetes, includes neonatal diabetes, and other sort of atypical inherited forms of diabetes as well. But that number probably makes up roughly about 10% of our whānau with diabetes across the motu. Part of the challenge is, and I think this is the hardest part of my job, is working out who has type 1 diabetes or not, or actually differentiating between the forms of diabetes, full stop. And just to be clear, that it's just not people on insulin. Type 1 diabetes is where the immune system attacks the pancreas, and that is how they become insulin deficient. Whereas most people also have pancreatic diabetes, and that's due to when there's any insult on the pancreas. It may be a surgeon, it may be cancer, it may be multiple forms of pancreatitis or cystic fibrosis, for example. Even though we have more people with type 2 diabetes on insulin than we do all the other types of insulin combined, at present, unfortunately, type 2 diabetes and gestational diabetes is not funded for either continuous glucose monitoring or automated insulin delivery. They do benefit from this technology. We're strongly advocating this space to get access. But what this current announcement means is that unfortunately most of your people with diabetes in your practice won't be eligible for this technology. But that message to get across in every country in the world where this technology has become funded, the first step has always been for people with type 1 diabetes. And so this is still good news for our whānau with type 2 diabetes, but it is trying to advocate for them to be included as well.
Absolutely. So what devices will be funded?
We'll start with continuous glucose monitoring. I've briefly mentioned the automated insulin delivery devices which will be funded. And to be fair, that's all going to come under the domain of secondary care. So I'll focus on the sensors that are going to be funded. So for most people, it's going to be what we call standalone continuous glucose monitoring or standalone sensors. They are sensors that don't talk with the pump. And there are two options. There's either the Freestyle Libre 2 or there's the Dexcom ONE Plus sensors. They're the ones that majority of primary care and secondary care will be starting people on. There's also sensors that talk to insulin pumps, and these are either the Dexcom G6 and G7 and also the Freestyle Libre 3 Plus. And they'll be reserved at this stage primarily for people that are on insulin pumps. So it's really about becoming familiar with that Freestyle Libre 2 and Dexcom ONE Plus sensors in particular.
So thinking about the role that primary care will provide, what do you see us doing?
One hard part is that the rollout of CGM is going to differ across the motu. A lot of the time, in many regions, a lot of that load may be on primary care, and others it may be on secondary care. Regardless, doesn't matter where you are in Aotearoa, not everyone who's eligible for CGM is under secondary care, so it is really important that for those in primary care are aware, and it'd be great if we could start people on continuous glucose monitoring. Even just wearing a sensor alone has been shown to improve glycemia. That's without any additional information or education at all. We do know, though, if we are able to provide that additional education and tips, and I'm more than happy to talk about these, how to minimize the stress and maximise benefit from the sensor, we can get even greater gains. There will be many people with type 1 diabetes in particular who have self-funded continuous glucose monitoring for the last few years. It would be great if primary care could do the special authority and just keep the scripts going for these sensors. You'll literally save these whānau at least $2,500 a year. I'm sure they'll be very grateful. They know what they're doing already with the system and can just go for it. The next group is those who are eligible. And the good news is that most people with type 1 diabetes have actually worn a CGM sensor at some stage in their journey with diabetes. And that's a lot's been through the free trials of either the Libre or the Dexcom. So they do know what CGM is about. And this is another group where if you are able to do the special authority and provide the script, they can hit the ground running and still make major gains. So there is one group though, which probably will need extra help, and that's the group that has never worn any sensor before. And this is a group where it may be that the practice nurse helps in terms of the education involved in inserting that first sensor and how to set the alarm settings. We're also trying to get pharmacists and pharmacy technicians on board to help. Basically, anyone that's got experience with CGM, it would be great that they can help. When you prescribe the CGM, it's just like prescribing any other medication or device. But the one thing which I am worried about personally, and being the biggest hiccup in all of the rollout, is a lack of stock in pharmacies. So even though you may do the special authority and script in primary care, it may be some time before they actually get the sensor from pharmacies. And this is a lot to do with our retrospective supply chain in Aotearoa. I'm sure that will fix itself within a few months though. So it's really about, in particular, it's just getting people wearing the sensors will be that take-home message, particularly, and it involves in that special authority and script. It's a very easy special authority. It should take less than 30 seconds. I know it's still, though, an extra step in terms of paperwork.
Great. So I wonder if you can just clarify. So the special authority application can be done by primary care, and we can apply for the initial application and the renewal for the continuous glucose monitor. Is that correct?
It's absolutely correct, Louise. And on that, I should also be clear that it's any relevant prescriber. So that's just not, GPs and GP trainees. It's also nurse practitioners, nurse prescribers, dietitian prescribers, and pharmacist prescribers. So it's the whole community care team can have a role in this. And it may be that you have a plan in your own practice in terms of who has what role. And it may be that the nurses take up more of an education role for those that need it. But it should be a relatively straightforward process in terms of just doing the special authority and scripts alone. And please remember that even though you can do renewal special authorities for insulin pumps and the infusion sets and cartridges, GPs or anyone in primary care cannot do the initial special authority. So that's part of the reason why pumps or starting pump therapy is all going to be done in secondary care, is that they're actually the only ones who can do that initial special authority. But it'd be great in 2 years' time, for example, if primary care can help out with the renewal of the special authorities. And that's very simplified again. It's just going to be if they're still benefiting. And to be honest, the answer is almost going to be 100% for everyone.
You mentioned devices. I just wonder if you can talk a little bit more to which device we should choose, a standalone device versus a linked device, for example.
Pretty much for everyone. Just to simplify it for primary care, I would be choosing a standalone device, and that's either the Freestyle Libre 2 or the Dexcom ONE Plus. Both are very good products. There are a few little nuances between them which may push you one way or the other. Or it may be that you go for the one that you're familiar with in the practice. I know that many practices are very competent, proficient at using the Freestyle Libre 2, for example. I'll go quickly over some of the benefits between the two. The Freestyle Libre 2 does have the benefit slightly longer sensor life, so it's 14 days versus 10 days. It's very slightly smaller. It does transmit glucose levels every minute, and it can be used in people on hydroxyurea, whereas the Dexcom ONE Plus can't. The Dexcom ONE Plus is still also liked by many. It has the benefit of having a delayed first high alarm. So what that means is that you can set the alarm not to go off in the first 2 or 3 hours after meals, which can be great in terms of reducing alarm fatigue. It's also more waterproof than the Libre 2 sensor, which I know many of our whānau will like. But one thing that basically choosing between the two comes down to personal preference. I would encourage people to look at the compatibility of the CGM with their phones. So just to be clear, to use CGM, that has to transmit the levels to either people's smartphone or to a reader if their phone isn't compatible, or to their pump to do automated insulin delivery. Now, the Freestyle Libre 2 is more compatible with older Android phones and will also go to Fitbit and Samsung Galaxy smartwatches for those that do want to hook it up to their smartwatch, whereas the Dexcom One Plus is just Apple smartwatch, for example, and there's slightly narrow compatibility. And we have these resources on the Pharmac website and the Diabetes New Zealand website, also making sure it's going to be on health pathways and in terms of helping to choose between the two.
So you've mentioned smartphones and smart watches. So will there be a charge for the app and updates?
All the apps are free. Unfortunately, there's going to be no smartphones provided for continuous glucose monitoring alone, but readers will be provided for free. Now, unfortunately, we can't prescribe readers because they're not technically a pharmacological device. So for people that don't have smartphones, how they get their reader is either online from going to the supplier's website, and we'll try and make this clear in our resources as well, or they can also phone the supplier of the device. So for Dexcom, it's Dexcom and NZMS. For Freestyle Libre 2, it's Mediray. People may be familiar with those companies. Or some diabetes services or PHOs are also getting their own stock of readers to distribute as well. But otherwise, there is no cost. These apps, they do get updated as we go along. So, for example, even though the apps may not be compatible right now with the iPhone 16, it will be with time. I would advise people on checking compatibility before necessarily going out and buying a new phone, if that's the main reason for doing so.
Fantastic. Thank you for clarifying that. So how many funded continuous glucose monitor sensors can a patient have per year?
It should last them the full year. They get roughly about 400 days supply. And as I understand it, if they do have faulty sensors, they'll still be replaced by the companies in between times. So there should not be a shortage. Some common troubleshooting or issues that arise, people's sensors fall out. And there are little tips to help with that. One is just making sure, going back to basics about how to insert a sensor. And there are really good resources on the supplier's website and on the Pharmac Diabetes New Zealand website, for example. It's remembering that at the moment, the Freestyle Libre 2 is just approved for the arm, whereas Dexcom's also approved for the abdomen and buttocks. And just being able to wear it somewhere else, that may be a reason to go for the Dexcom One Plus. You can use adhesive overpatches. In fact, the Dexcom One Plus comes with one. You can actually just use a $2 sports bandage. And often that will do the trick in terms of keeping the sensor in. And it's just taking care of the sensor. I'd actually really encourage every healthcare professional who hasn't worn CGM before to wear one, just to know what it's like. Insertion itself, I think, hurts far less than a blood test or finger prick. That will hopefully not be a barrier for many. But it's just even knowing how to take clothes off or dry myself after getting out of the shower to minimize any disruption to the sensor. It's just those sort of basic tips. There is good guidance out there.
Wonderful. So we get our patient on a CGM and they come in with their first data set. This may be quite new for us. So what do we need to know about interpreting the data?
Yeah, and it may be new for your person with diabetes in front of you as well. This may be the first time that they've ever seen all their glucose levels over a 24-hour period, because finger pricks do just provide a snapshot. Part of that, I think it's really good for every healthcare professional and person with diabetes to know what a normal CGM trace looks like. It does go up and down. For example, it doesn't matter what I have for breakfast. I'm lucky enough not to have diabetes, but my glucose levels will go into double figures before coming down quickly. I'll often be in the threes despite not being on insulin and sulfonylureas. So it's one, being aware what a normal trace looks like. And then it's getting used to looking at the metrics that we look at as part of our targets, for want of a better term, for diabetes. So the most commonly used metric is time in range. Now that's the percent of glucose levels between 3.9 to 10 millimole per litre. And for most people, we're aiming for more than 70% of their day in range. Now, one good way of motivating people towards that is every extra 1% increase in time in range, another 15 minutes with glucose levels in target. It also means if you're only aiming for 70%, they can spend 6 hours of the day outside, above range, which is also really reassuring for many whānau with diabetes. We're aiming to minimise that time below range for people on insulin and sulfonylureas. I think ideally 0%, but up to 4% in mild hypoglycemia, and that's really probably between that 3.5 to 4 millimole per litre is thought to be acceptable. We're definitely not aiming for anything below 3.5 millimole per litre. The other metric which people are very familiar with is the glucose management indicator. That is calculating basically the equivalent HbA1c. So for most whānau, we're aiming for less than 53 millimole per mole. We may be aiming slightly tighter for young people or in pregnancy, before pregnancy. At the same time, we may be aiming for slightly more relaxed targets, e.g., a GMI of 60 to 65 millimole per mole in the more elderly people. If you have at least 60 to 90 days of data, the GMI is very accurate compared to laboratory HbA1c. In fact, for our whānau wearing CGM, I'm sure we actually stop measuring most of our HbA1cs. It will become a test of the past. This is how big CGM is in terms of the shift in diabetes care.
Gosh, that's wonderful, isn't it?
It is.
So what about pump failure? How common is pump failure?
It will happen. And I guess what automated insulin delivery does allow, it allows, a lot of the time people's access to technology was actually gatekept by healthcare professionals themselves. People weren't thought, to be necessarily safe on insulin pump therapy. Automated insulin delivery blows that out of the water. So now pretty much everyone will be able to get success out of automated insulin delivery, but there is always, some failure rate. It's about making sure we keep people safe. The good news is when you're wearing a sensor, if the pump fails and glucose levels start going high, people do get a warning. It's just for people that aren't aware, in an insulin pump, you only have rapid-acting insulin on board. So what that means is say if the insulin stops going in for whatever reason, that they can actually start developing ketones and eventually diabetic ketoacidosis or DKA within a few hours. So it is really important that people know what to do when their pump fails, and this should be part of the education when everyone started on a pump, and everyone should have a sick day management plan or a pump failure plan, and this is where it's important to keep in touch with secondary care. But what that means is if the pump fails, they can go back to using pens. So people on insulin pumps still need insulin pens. They still need long-acting insulin, either Lantus, Protafane or Humulin N. They still need pens to give their Novorapid, Humalogra or Pedra. And there are basic tricks in terms of working out, how much Lantus they should be on, for example. And they can actually just use their initial pump settings, for their mealtime and correction insulin as well. If you're not clear of what the sick day management plan is, then there will be an example put on Health Pathways. You might phone up secondary care in that instance if you're unsure. But the biggest thing for all of troubleshooting is that everyone should have at least a piece of paper or a plan to know what to do when that happens, and you advise them to follow that plan.
And do they need to actually carry that extra insulin with them, or I suppose they have enough warning?
Yeah, no, they don't necessarily have to carry it with them for everyday life, but what it does mean if they were going to go away for the weekend, or particularly if they're going to go on overseas holiday, that is a time where you would plan, and making sure that as a prescriber in primary care that they've got enough supply. And that will include, just for example, that worst case scenario, if someone's bag got stolen or lost, that they have extra supplies if needs be. Insulin can't go in, or ideally you don't put it in the hold of a plane, because it can freeze and become deactivated. So you have to carry it on their hand luggage. These devices ideally don't go through full body scanners at the airport. So it is maybe that you're providing a travel letter to say that that they have diabetes treated with CGM. Can we find alternative forms of security? So that may be something that you do to support in primary care. But just to be clear, for pumps, almost all of it will be done in secondary care, and that they should have a plan. I know it doesn't always happen that way, but they should have a plan to cover every worst case scenario.
Wonderful, thank you. So if a patient was wanting to know more about either device, where can we send them?
Pharmac and Diabetes New Zealand have been leading this space. There's also the Clinical and Youth Network, particularly for our tamariki rangatahi with diabetes. That's a useful site. Healthify are starting to ramp up their resources as well. So, and we will do so from NZSD too. So there are various places to go to. I would recommend going to one of those sites, or at least a legitimate site, rather than social media. There has been, I guess, one of the biggest causes of fear or people getting upset is now Medtronic devices won't be funded. And we did have quite a few people on Medtronic pumps, and now they're going to have to be transitioned over. Now, if you look at all of these systems, to be honest, in both RCTs and in real-world data, there's no sort of difference in efficacy or failure rates between Control IQ Tandem versus MyLife Ipso Cam APS versus Medtronic 7AG SmartGuard. So these systems are good systems. I think Pharmac have actually done quite well in terms of being able to cater for as many of our whānau with type 1 and pancreatic diabetes across the lifespan. But it is going to be a challenge for some. There is still a lot of that anxiety and fear out there. It's how we're going to help allay that fear. A lot of it's too in healthcare professionals too. I know that Tom Wilkinson's going to be doing a webinar at probably the same time this podcast came out on Goodfellow to help get people up to speed on what this technology is. It really is people's friends. It's going to change the way that we work. And I would encourage people to get familiar with it.
So to conclude our podcast today, Ryan, your take-home messages.
Well, I think it'd be great if all of our whānau who are eligible can have a script and special authority done for continuous glucose monitoring. And if they do have any issues, well, I haven't mentioned this before, but there will be troubleshooting in terms of technical support supplied by the companies. And if it's a technical issue with the sensors, that should ideally be going to them. Don't want to be dealing with that in the practice. So it's about ensuring that they will point them in the right direction for resources, so they know who to call when they need help. This will be a big carrot for many people who were previously under secondary care, but have given up on secondary care, all of a sudden want to go back in to get an insulin pump and automated insulin delivery. And the biggest role of primary care in this space is actually going to be referring people to secondary care. That's not going to be starting pumps. Don't worry about that. If you can give people CGM, that would be absolutely fantastic. And just keep the communication going. This is a really dynamic time in diabetes care for both primary and secondary care. So I would encourage you to talk to your local diabetes service. They're probably doing their own education in your region. We are trying to increase that across the motu as well. But it's just doing all that you can for our whānau with diabetes. I know that everyone's stretched, and just thank you in these stretched times. It is difficult.
Wonderful. Well, thank you for your work in this space and for your time today. It's been great talking to you, and we've got some great learning points to take away.
Thanks, Louise.
So if you're a New Zealand GP and would like to claim CPD points for listening to this podcast, our podcasts are eligible, so please log them. You'll also find a list of resources that Ryan has mentioned and were used in making this podcast on our website, goodfellowunit.org. Thank you for listening.